Hi, everyone. Welcome back to MedFluencers Unscripted. My name is Dr. Adam Goodkoff, and I am joined by,
Hi guys, Jordan. Great to see everyone.
thank you everyone for tuning back in. Today we have a very exciting guest, Dr. Singhi, at Lung Onc Doc. Did I get that right?
You got it right.
I love it. You are a thoracic medical oncologist, very passionate, of course, about education and teaching, especially in young onset lung cancer. You're located in Houston, Texas. Welcome onto the show, Dr. Singhi.
Thanks for having me, guys. I appreciate it.
Great to see you. And it's great timing as November was just Lung Cancer Awareness Month. The State
Yeah.
of Lung Cancer report was just released. So I know there's some data there we want to dive into. But I mean, first, if you don't mind, can we kind of take it back to the beginning of your journey into medicine and how you decided to pursue oncology?
Yeah, no, absolutely. So, my grandfather was actually a family medicine physician. And so, growing up, I used to talk to him a lot and sort of to hear about the sacred patient physician relationship and what that meant, not
Mm-hmm.
just in the clinic, but outside of the clinic, and hear the stories about the impact that he had on not only the patient he saw, but obviously their families. And it really meant a lot to me growing up, and something I was really excited I could see myself doing. And so then fast forward to getting into medical school, learning about all the exciting advancements in oncology and really everything that patients with cancer have to go through, from the physical aspects to the emotional aspects. Combine that with all the advancements we've seen in the drugs, got me really excited, found really nice mentors, and really focused in on thoracic oncology since then.
Tell us about, and I'm really curious because obviously I'm in emergency medicine, very different field. How are you staying up to date or keeping up with the literature? Because the pace at which oncology is developing is so much. I got to imagine even when you were a resident, right, or even a fellow,
Yeah.
that it's so different year to year. It's almost impossible to keep up. What are kind of the tools in the arsenal, or how are you doing that outside of like traditional conferences and things like that?
Yeah, no, that's a great question. So actually, that's how social media really came into my life. So I was using a lot of X, or Twitter as it was known back then, to keep up with all of the academic chatter, the latest updates, see what experts were thinking about new drug developments, new clinical trials. Everything is just so subspecialized now. So I have a lot of admiration for general hematologist oncologists because there is so much to keep up with. There's constant new FDA approvals, new trials, a lot of data. And so I was keeping up with it through social media, to be honest, in the beginning, learning, trying to educate myself, trying to educate others. And then that's when I shifted only recently, about a year ago, getting onto Instagram and TikTok to be more patient facing, to say, hey, listen, I've learned the knowledge. Now I want to share that knowledge and increase patient education.
It's interesting. We hear that knowledge sharing or knowledge translation component a lot. You talk briefly about your transition from X to Instagram and video platforms. What do you see as the value of being an oncologist outside of just communicating to patients? But why video? Why not just write tweets to the patients?
Yeah, it's really interesting. It was a really hard shift, to be honest, because I have so much admiration for influencers like you, who are seasoned, that put out such great content. It takes so much time to put together video, visual content. And so that was one thing that was really hard for me when I first got onto Instagram and TikTok, because drafting a tweet is very quick. It's primarily text based. If you want to add one still image, a lot easier. I think really getting patients to be involved in their care and empowered in their care requires really unique ways, innovative ways to get them excited, to help them learn to bridge that gap. They often say that a picture is worth, 1,000, a million words, if you will. And so having the ability to get involved with that, really spending some time trying to create content, was new but exciting, and it's really paid off. I've been able to see a direct impact at the patient's bedside because of it. And it's something that I'm really excited about.
And I would also imagine with social media, it's led to opportunities with peers as well.
Absolutely. Yeah. So, one of the things that I've been trying to push with regards to my research focus is patient education. And so, a lot of times we're so excited trying to move forward all these drugs in this space, but we really don't take the time to take it back to who really matters. And that's the patient, right? Explaining why this drug is better than one other drug, what potential side effects to look out for, really empowering patients to be a partner in their care. And so I really wanted to push that forward, but I was having trouble really connecting with patients, understanding their need, figuring out how can we help them navigate to reach that point. And so social media really helped bridge that gap. It provided more insight about what patients want, what they're hoping for, and then bringing that back to my scientific community and saying, hey, listen, this is what I'm getting. How do we bridge that gap? And so lots of opportunities have opened because of it.
Do you think that because we hear a lot of times, right? Patient to physician makes a lot of sense. People come on social media and they're like, this is amazing. I can learn from an oncologist. Like, what a wild opportunity. In your experience, do you feel that other physicians and peers of various training levels are on social media and listening as well?
Yeah, I think so. I think it's really shifted in terms of what we're doing and the stakeholders that are involved with social media. So institutions from, an academic to private to hybrid, they're on social media, obviously patients and their loved ones, and even providers, not only, physicians, but APPs, nurses, pharmacists. It's been really exciting to engage with all the different stakeholders on social media. Everyone's got a voice, everyone's got an opinion. And really, I think the best way we're going to advance our care for patients with cancer is if we listen to each other, we learn from each other, and we engage.
Absolutely. Yeah, and we're obviously biased, but we think myself doing this for 8 years, I think there is a huge amount of underreported peer to peer education or connection that happens on social media, and I think we can become numb to the volume of videos, but I think we also really listen and kind of there's a lot of crosstalk there, and especially in a field like oncology, where again it is developing so quickly. Having experts like yourself is incredibly important, and I'd love to transition on that to the lung cancer world a little bit. Tell us, let's set the stage, because I think a lot of folks think of, and I can, even as a physician, I can tell you, like, I think of hemonc as like, it's a thing, right? Forget the
Yeah.
subspecialties. I'm like, they do the cancer thing. I call them when there's a problem with the blood thing or someone's on cancer treatment and they need to be admitted for their neutropenic fever. But like, what specifically drove you to lung cancer? What should someone know about lung cancer? And obviously, I'm sure we'll get there, but
Yeah.
it's not just smokers. Like, what do we need to know?
Yeah, no, you're highlighting a lot of great questions. So, lung cancer is the leading cause of cancer related deaths globally. And so, just to put that in perspective, about 235,000 Americans this year are going to be diagnosed with lung cancer. Close to 130,000 Americans will pass away from lung cancer. What I've told people is that the face of lung cancer has changed over the last 15 years. We've seen this shift as there is increased efforts for tobacco cessation, right? So we're seeing less causes related to smoking because we're doing a really good job with public health efforts to decrease that. But we're seeing an increase in young patients, particularly females and patients who have never smoked, that are getting
Wow.
lung cancer. Yeah, which is something people don't know. I meet a lot of these patients and their loved ones in clinics for the first time, and they said, no one told me that you don't have to smoke to get lung cancer. And it's just eye-opening and so surprising for a lot of these patients.
What are some of the early signs, right? We'll take the smokers out of this. Like
Yeah.
for folks in, non-smoking condition, what are the things that you're seeing that patients are coming in with as kind of that initial impetus for diagnosis?
Yeah, Adam, it's so variable, to be honest with you. I've had this recurrent story of patients having a delayed diagnosis, particularly patients with young onset lung cancer. So typically the average age of diagnosis of lung cancer is right around 65, 70 years old. But as I said, we're seeing the shift in earlier diagnoses of younger patients. And so what I've seen recently is just this delayed diagnosis where a young patient, less than 50 years old, who's very fit, has a young family that they're taking care of, very active, they'll be having a cough that doesn't go away for a while, feeling maybe more short of breath, more fatigue, something just doesn't feel right with their body, right? And they'll go and seek out care to an urgent care or go somewhere else, and they'll say these symptoms, but often they're met with, oh, it's probably just a viral infection. It's probably asthma, anxiety, you name it. And then months go by until they really get into trouble and then eventually get a biopsy, find out it's lung cancer, and then they make their way to me. And so trying to just get the word out there that even young people can get lung cancer, even patients who don't smoke can get lung cancer, advocating for your body, advocating for your health if you recognize any signs that just don't feel right is so important. And that was the whole point of really Lung Cancer Awareness Month in November.
Yeah. So it sounds like people should be asking their doctor about potentially getting those exams regardless.
Yeah. So right now, when we think about lung cancer screening, it's limited by the USPSTF to patients that have that traditional high risk factor, and that's a smoking history. We're trying to do better. There's active areas of research right now looking specifically at patients that don't have that traditional risk factor. So patients that have maybe a family history of lung cancer, or patients that are maybe in other non-traditional ways at a high risk of getting lung cancer. That's active research. But what we have right now, unfortunately, is only limited to patients that are ages 50 to 80. They have to have a 20-pack year smoking history. and they're either still smoking or have quit in the last 15 years. And so even with that, though, I'll tell you, for this lung cancer screening criteria, only about 16% of Americans that are eligible that meet all that criteria are the ones that are actually going to get the lung cancer screen.
Wow.
So
Yeah.
it's not many, and we're doing a really poor job right now. So we got to do better.
Yeah. I will tell you, I've seen the billboards with a CT scanner on like a bus stop or something like that. So it's getting out there. I think probably opportunities to reach patients where they are on social media there as well. Are there, and I want to come back, so don't let me forget this, because I do want to kind of push a little bit on lung nodules, which is a really interesting topic to me. And we don't usually get too medical here, but I think especially hearing this, that like we know the guidelines aren't going to catch up for a while, especially with how fast oncology is moving. So I want to come back to that. But first, if we put that in a bucket of, well, we can't do the low dose chest CT, or, you know, we're not even recommending an X-ray, is there genetic factors that we're looking at now? Are there, you know, is there anything early, I suppose? And we won't hold you to this, is not, of course, never medical advice, but like, is there anything that's kind of floating around that, hey, maybe there are some, you know, genetic testing that we should be looking at for high risk factors?
Yeah, so we're still trying to learn a little bit about genetic risk factors related to lung cancer. I think we're ahead of that in terms of breast cancer and sort of some other cancers. But in lung cancer, there's really one mutation that we look at right now that's related to an inherited risk factor, which we call germline mutations, so passed from parents to children and so forth. What we're really looking at in lung cancer when we talk about genetic testing is what we call acquired mutations. So acquired mutations are mutations that are developed really only specific to the tumor cells, the cancer cells, and that's over a patient's lifetime. These are not mutations that are passed to children, not mutations you got from your parents. They're restricted only to the cancer cells. These mutations don't exist outside of the other cells in the body. But those are really important to look at, definitely, because we found different therapies that are very targeted and specific to those mutations that patients have.
Interesting. So I guess going back then to my nodule question for a second, and again, you know, there's a part of me that's like the ER brain is just there. I see countless scans. I'm pasting results into discharge instructions. Follow up, you know, go check with your primary on the guidelines. Are we seeing a change in the guidelines at all on like lung nodule? Do you see, anecdotally, like, do you see that finding a lung nodule is actually leading to a cancer diagnosis in someone who's otherwise healthy? Or is it, you know, more typically these kind of, oh, we'll watch it, we'll, you know, scan again in a couple of years? Like where is it on that spectrum? Because it seems like from the ER lens, at least, it has become ingrained that like if there is an abnormal finding, it needs to be pasted. You need to discuss it with the patient. You need to make sure they follow up on that, you know, screening guideline. And I know American College of Radiology has a set of recommendations. So where does that shake out?
Yeah, no, I think that's a really good question. So a lot of institutions are starting to develop these incidental pulmonary nodule clinics, or IPN clinics, where they really are following those guidelines very strictly that are set forth by radiology and making sure that patients have routine follow-up. Of course, you need to act on these nodules more quickly, or if there's concerning features from a radiographic standpoint, if they've got clinical criteria like, you know, their smoking history, for example, that's really important. But, you know, there's definitely still some studies that are ongoing. For example, actually in Taiwan, they're doing a national lung cancer screening study where they're looking at patients to see that don't have those traditional risk factors of smoking. They're looking at patients that have a family history, for example, and they're looking to see if that also really leads to higher rates of cancer diagnoses earlier. And they've actually succeeded. And so there's a lot of exciting efforts there in that space, I think, and especially with nodules. You're right, really need to adhere to those guidelines for now. But let's see kind of how that transforms for the future.
Jordan, you must have a lot of questions floating in your head, because I don't usually jump in this much, but I think anytime I get to pick an oncologist's brain, it is fascinating because it is such a world aside from traditional medicine. But in the more layperson realm, Jordan, does anything pop to your mind as areas of interest here?
Well, first I'm thinking I need to sprint to my doctor and get my follow-up exam. But it is actually interesting to me. Something that I feel like you've really touched on is patients advocating for themselves. When they just feel internally like something's off, they're not getting the answers, like how you've said, maybe they'll be like, oh, they think it's asthma, whatever. Is there anything more you'd want to expand on there about just really trusting your internal instincts and maybe pushing back? Not that these providers are not amazing, but you do hear these stories where people are like, I'm not getting the answers. I feel like I'm not being heard. And I'm sure you see this sometimes too.
Yeah, no, this is a really good question, Jordan. You know, I meet patients when they're completely just shocked and surprised right after they get that big C diagnosis. That's when they come to the oncologist and they're just left to figure it out and try to empower themselves and educate themselves very quickly. And so the question and sort of the response that they tell me every time is, I wish I had told somebody sooner. I wish I'd pushed more sooner. It's really hard. It's really hard because a lot of these patients will have almost fragmented care, right? Well, they'll go in for an acute symptom in a singular moment, and they'll present to an emergency room or an urgent care, and they don't get the whole story put together, right? Especially if they go to different locations and centers, it's really hard to have that comprehensive care. And so the one thing that I would tell people is have longitudinal care, right? Like make sure you have a home base for a medical center and say, you know, the person knows who you are. They know what your baseline is. You're able to have that really respectful relationship, like the relationship that my grandfather had with so many of his patients, right? Growing up as a family medicine physician. And so I think that's the biggest thing, having longitudinal care and making sure that someone is really advocating for you and you're advocating for yourself.
Yeah, I like that. Are there, looking to the future, right? We've talked a lot about clinical trials. Are there any that are particularly stand out in your mind as exciting? Anything that's cutting edge right now? And I have a follow-up question to that, but we'll kind of start there as our segue.
Yeah, I think a lot of our clinical trials right now are looking for biomarkers. So these different mutations, for example, are some way just to personalize our treatments for patients with lung cancer. We've been doing a really excellent job as a scientific community of doing that. I think understanding the biology of the tumor and moving away from just cytotoxic chemotherapy, blanket chemotherapy that just kills the fastest growing cells. How do we move away from that and really personalize treatments? And that's what we're most excited about as a community.
Can we, for those who don't know the difference, can we kind of define like cytotoxics versus like biologics and targeted therapies and like what that whole new realm of medicine is?
Yeah, absolutely. So chemotherapy is kind of what everyone's known for years, right? It's this sort of drug that's given largely intravenously through the vein, and it's a drug that's killing just fast growing cells somewhat non-selectively. And so that's why you can have sort of off pathway side effects of diarrhea because it's killing really fast gut cells. You can lose hair because it's killing really fast growing hair cells. That's the traditional chemotherapy that we've had for decades now. Now, in other types of cancer treatments and lung cancer treatments as well, we have a bucket of drugs called immunotherapy, which works very different than chemotherapy. The way it works, I tell patients, is it's teaching your immune system to recognize the cancer cells. Cancer cells often wear a cloak, and they do a really good job of hiding from the immune system. And so what the immunotherapy does is it pulls the cloak away and it exposes the cancer cells to your immune system, to your T cells, which are like the soldiers of your immune system. And it says, hey, there's this foreign substance essentially in your body. Now you can recognize it. Let's go after it. And it revs up your immune system to go after it. So it's a really novel way of thinking about how we treat cancer. It's been very successful in lung cancer and other types of cancer treatments. And often we're using it not just by itself, but sometimes in combination with chemotherapy. And then the last sort of bucket that we talk about is targeted therapy. And so targeted therapy, many of them are oral drugs now. What they're doing is they're drugs that patients can take once, sometimes twice a day at home. And we found those mutations that I referred to earlier, those changes in the DNA of the tumor cells that are causing and teaching the cancer to grow. And these oral drugs basically will attach to protein receptors that are highly expressed on the cancer cells, and they'll help shut down that pathway. So it's really targeted, it's precision medicine, it's really the way of the future.
Could you, for some of the learners, I think, sometimes we have students that listen to these, non-branded, non-sponsored, but could you give like an example or two of a drug in each of those categories so that folks can kind of tie a name to like, and it's going to vary, right, by disease state, but even just in lung, like what is a chemotherapeutic, what is something on the immuno spectrum, and then a targeted?
Yeah, absolutely. So for chemotherapy in lung cancer, we really think about a platinum carboplatin-based regimen as a traditional chemotherapy regimen, and you can pair that with different chemotherapy drugs based on the actual histology, the cells of the lung cancer. So pemetrexed or paclitaxel, you may have heard of for chemotherapy. Immunotherapy, just to give an example, one would be pembrolizumab. It's taking advantage of that anti-PD-1, anti-PD-L1 pathway. And then for targeted therapies, one that I'll just give out as reference is a drug against an EGFR mutation, and that's osimertinib. So those are kind of three examples.
So those are for the students, the MABs and IBs. That's where we're getting into those crafted
I'm a
therapies.
Student today in this episode.
yeah, Jordan. Welcome to the world of oncology.
So I'll tell you this, my younger brother is a second year going on third year med student. And during his first year of medical school, he was in his hematology oncology block. And I went home for Thanksgiving and we were just like walking outside and we shot a little video actually. and I was just quizzing him on how you pronounce the names of the drugs. And he
Yeah.
actually did a really good job. I'll
Yeah.
say he did a really good job, probably better than I would have done my first year
Nice.
in med school.
Proud brother moment.
Yeah.
Yeah. But it's just so funny because he studies them. He knew all the pathways, he knew the mechanisms of action, but saying it out loud is not easy. And so maybe that's one thing we need to do is reinvent the names.
Oh, the names are
The
wild.
names are awful.
It's really interesting though to hear that he knew kind of the pathways, because I think even some things we're talking about today, we covered them in medical school, but it wasn't like the drugs that exist now didn't exist when I was in medical school. So it's like you really like when I hear about these, or in prep for an episode, I really have to go like look things up, and a client calls them, I'm reading like, oh wow, it's interesting, like I didn't know we could target this pathway. So it's good to hear that it's making to the medical school curriculum that quickly.
I think it's really hard for them too. Like I'm just thinking about how much knowledge they have to continue to learn, and they're trying to move up clinical rotations even sooner. It's a lot. It's a lot of pressure, and
Totally.
they're almost thinking about subspecializing and what to do much earlier than we had to think about, right? So, you need to interview a med student soon, I'm sure, on this podcast just to say what's going on with med school now.
Yeah, that would be interesting. Do you think that there's a world where the chemotherapeutics will really become de-emphasized? Or do you think that's always going to be a mainstay?
Yeah, I think chemotherapy definitely has its role for sure. Sometimes we have to move quickly, especially if patients are in crisis or they have a large tumor burden. And chemotherapy is definitely probably here to stay for certain, patients and in certain clinical situations, I think. I think what we're trying to do is see if we can combine it with new drugs, right? Is there a boosted efficacy, for example? Of course, you have to think about tolerance. And what really matters is quality of life for patients and side effects, right? Like you don't want to just keep treating someone without really factoring in how they're feeling on treatment. And so that's so important. So we'll see, but I think it's probably here to stay.
Yeah. And I feel like that segues in a little bit to kind of back to clinical trials. I would love your thoughts on how, if someone's kind of exploring different clinical trials, identifying if they're a good candidate for them and like the questions they need to be asking their doctor.
Yeah, that's a really good question, Jordan. I think we have a lot of trouble with it. We're still trying to learn what's the best single resource, right, to help patients find a clinical trial, advocate for themselves to get on it, and then get started, right?
Yeah.
There isn't a great single resource, to be honest. And so oftentimes a lot of my patients will Google things and they'll find criteria. There's just sometimes very strict eligibility criteria. And a lot of times it's about the timing, right? Is there an open slot for enrollment? And so what I would say is if patients are interested in clinical trials, definitely talk with your healthcare provider team about it. If there is an academic medical center that's nearby as well too, seeking out for a second opinion specifically to ask about clinical trials is something that's absolutely okay. Patients just need to know that it's okay to ask questions. It's okay to go see another team if you're interested in clinical trials, get that information. Otherwise, I would say, the NCI, the National Cancer Institute, does have a website with, you can search and look for different tools, but I think we're still trying to learn. And maybe this is an opportunity for AI and technology to help match patients to clinical trials and make sure eligibility criteria really fits.
Yeah, something we've talked about, Eric, and I think it's interesting is there a role for social media in identification of potentially patients for clinical trials? Because we reach so many folks with a post, right? Is there a chance where you can talk about a particularly exciting trial, something that is groundbreaking, and maybe a patient group finds that or sends it to someone who has a particular type of cancer or marker? What are your thoughts on that?
I think that's a great idea, Adam. And I've actually done that, not so much for clinical trials that are ongoing, but recent FDA approvals, things like that. And so I did a video about in small cell lung cancer, right? When you think about small cell lung cancer, there's been a lot of doom and gloom and not so much hope for these patients. It tends to be a lot more of an aggressive lung cancer. But recently, in the last year or 2 years, we've seen excitement, we've seen advancements for these patients, and it's been decades since we've seen that. And so I did a video on an FDA approval that came out earlier this year and got so many messages and excitement from patients about this drug, sending it to their loved ones saying, hey, listen, there may be an option, right? And so I think just getting the word out about the drug and then having patients have that conversation with healthcare providers, with patient advocacy groups is so important. So I love that idea. I'm all in favor.
Yeah, I still get the chills when I hear stories like that. There's an impactful one from Dr. Janasia, who you may know, and he had a similar story. Very short version of a long story is that a patient found a video of his, found out that actually she could get tested for a particular genetic mutation, ended up being a candidate for a therapy, and is now cancer free. And it's like,
oh wow,
yeah. When you hear that, it's reinforces the power. Anytime someone kind of knocks you down for making social media videos, these kind of things, it's like there really is power in the communication that we can give to other patients and to other HCPs. It reminds you why you do it.
And to give hope, especially with what you're doing. Like you said, it's always, it doesn't have to be so doom and gloom, and empower people a little bit too.
Yeah. I was trying to figure out ways to combine sort of hobbies and interests and fun with educating. And so one of the things that I did was I started dancing, right? To about updates and excitement. And so it was really hard to put myself out there, I think, initially. I actually used to do some dance back in high school and in college, some Indian dance like Bollywood and Bhangra and things like that. And so I always had a lot of fun, like tapping into my creative side. And so then fast forward to social media and using it, I was like, why not just do some dances, get some knowledge out?
Yeah.
And those have probably been like the most interactive, the most engaged that I've seen in terms of like viewers and comments and sharing. And so people have received it well. And I think people learn in different ways, and it's okay to embrace and try new things. So that's my take from social media recently.
I love that. We have in the subspecialty area, I find this in particular, physicians seem more hesitant to get on social media, and they don't even have to dance, right? We know that you can do other kinds of videos that are very engaging or helpful. If you had one or two pieces of advice for a colleague, right, who's in hematology oncology space, maybe they don't feel comfortable because everyone else is on Twitter or they're at ASCO doing whatever. What got you comfortable going there?
Yeah. The way I got into social media actually was when I was during my training. And during my training, I was in fellowship, hematology oncology fellowship. And kind of 6 months into training is when COVID happened. And COVID, as we all know, was a very isolating experience. There was a lot of misinformation, and we still wanted the information to figure out what was going on, right? How are we going to navigate these times? So that's when I turned to X and Twitter at that time. And sort of mistakenly is how I found the lung cancer social media community on Twitter. I was looking for just cases of trying to understand how we know if COVID is what's the problem for patients that are having lung infections or strange findings on their lung imaging, or is it the lung cancer? It was really hard to tell. So I remember searching for this, finding some images, somehow finding experts in the lung cancer field at that time that were there, unpacking data. And I was like, wow, there's a whole different community out there. I remember interacting with them and starting to engage with them. And it became a lot of fun, right? Like learning myself, educating others, thinking about different ways to communicate and embrace sort of that experience. And it became less isolating. It made COVID way less isolating. And so that's how I got into it.
Yeah.
I think advice for people, when you're thinking about embracing social media or engaging it, one is don't overthink it. I think sometimes people spend so much time trying to perfect what they're going to say before they say it that they've sort of lost the momentum. They've lost the opportunity. Mm-hmm. And so I've learned to kind of just go with the flow and not overthink it. And then the second thing I would say is really think about the impact beyond what you're trying to put out just directly, right? So like for me and the story you shared out on the Dr. Juneja's patient, thinking about the potential impact that this can have for patients directly at the bedside, that's also why I do what I do. And so I think those would be my two pieces of information that if it can help even one patient, it's worth it.
I love that.
Just do it.
Just do it, yeah.
It's the Nike of social media.
Yeah.
But I would imagine as well, because with what you do, there's a lot of highs and lows. And so then if this brings a little bit of joy, happiness, creative outlet to you, that's probably helps to compartmentalize those lows as well.
Yeah, no, that's a great point. We're seeing a lot of physician burnout as well, yes. Right? Not just in oncology, but every field. And so if there's something that fills your cup and you can combine it with your work and it becomes a passion and excitement, I find it so rewarding to be able to do this. I'm so grateful that I get to do this. And I really enjoy it. So
I want to go deep for a second with this question, Eric. And this is something that I've reflected on, but I'll withhold my opinion until you get to answer. Has practicing oncology changed your perception of life in any way in particular? I have a guess of what the answer might be, but are there any take-homes that after practicing for the time that you have, you view things in a different light or in a different way?
Absolutely. My focus has really become young onset lung cancer. So I'm seeing a lot of patients that are 50 and younger. And first of all, no one deserves to have lung cancer or any type of cancer. But when you see yourself and your patients, and I'm starting to see myself and a lot of my patients, this younger population, it really reminds you just to be grateful for everything that you have, right? To embrace and enjoy every moment. One phrase or quote that I've heard that really has stuck with me is, patients don't just want to survive, they want to live, right? And so really thinking about how we can help people live, enjoy their quality of life, and thinking about that has really shaped and changed the way I look at a lot of things. And so, Adam, yeah, very insightful question.
Yeah, it's funny. I think every physician has a way or connection to that. Obviously, for me in the ER, it's trauma, right?
Mm.
And like, there's no, for anyone who hasn't gone through it, it's very good for them in their life if they've never had a traumatic loss. But obviously, as an emergency physician, especially training in Chicago for my residency, like we would see this all the time, and it's horribly crushing. And I had actually worked through one of the shootings there, not
Oh,
not
wow.
a gang shooting, like a mass shooting at that parade. And
Wow.
you talk about seeing your patients and yourself. It like those are like brain chemistry changing moments, and I think it has changed to the core, not just that moment, but many of the things that I saw, the way, not only the risk tolerance that I have for certain things and do or don't do, but also the way that I view life and savings and experiences. And I think we do get this really unique view as a physician of this kind of like finality of life. And as beautiful as it can be to help people, it also can be like incredibly dark to see this. And I think it for me at least has really changed the way that I try to appreciate and, like you said, approach every day, try to take something good out of it. I mean, I'm not going to be like overly optimistic and say every day is great, right? We're still human, and there's days where you're just like, please make it end. But it puts things in perspective a lot, and I think that's that has been powerful for me.
Yeah. But
Yeah.
how rewarding to touch so many people's lives too. And just,
Yeah.
Couldn't agree more.
yeah.
I'm looking for a quote here on the side. So I met with someone recently. It's called the Nightbird Foundation. So this woman was on, is Jane Marzowski, I believe, but Jane was her. Nightbird was the stage name, and I can't remember. She had breast cancer, I believe. But she has like a really impactful quote. And I met her brother recently, who runs the charity that helps women with breast cancer afterward. And of course, I'm not going to be able to find the quote now, but I encourage anyone who's listening. Here it is. Okay. You can't wait until life isn't hard anymore before you decide to be happy. And I thought that
Wow.
was like
Wow.
really, really impactful. And
Yeah.
it's a total, this podcast has really gone down a side street for today, but I think it's important. And we've gotten into kind of this like deep space of life. And that quote, I think, hits at every stage of life, especially for folks in healthcare who are listening. You're in medical school. You're like, well, I will be happy when I'm a resident and I get into the program I want. You're a resident. And you're like, well, when I get my fellowship, then I'll be happy. When I get my attending job and I finally make money, I'll be happy. When I pay off my loans, then I'll finally be happy. And all of a sudden, right, greater than 50% of your life is gone. You have worked all this time and you forgot to be happy along the way. So I thought, aside from an amazing story, and I still encourage everyone to go, read about Jane and her story. And I mean, it's a beautiful audition on America's Got Talent, but that quote stuck with me and makes me think of this.
Yeah, no, I really like that. And it just reminds us of delayed gratification, like the way you said it, right? Where we're just constantly pushing ourselves to that next goal, that next post line. And you're right. You just got to enjoy the moment. You got to embrace it now. So
Yeah.
I love that.
Wow.
Absolutely.
That's something I want to write on my a sticky note and put on my laptop. So like I see that every day.
I know
Yeah.
they have like awesome merch and stuff that supports the foundation there. And it's like, it's on one of my tabs. That's why I was looking through all my Chrome tabs. I'm like, I got to get something because it's such a uplifting thing to hear. But bringing it back to you, Eric, as we kind of wrap up these things, we always like to ask, is there anything that you would like our listeners to know? Anything you're excited about, anything coming down the line, that kind of stuff?
Yeah, no, I mean, first of all, just grateful to be here, coming right off of Lung Cancer Awareness Month in November, just getting the word out there about lung cancer. And, I think a lot of times we're focused on all different other types of cancers, so breast cancer, for example, which definitely needs a lot of research and awareness in October. But also knowing that lung cancer is also a women's health problem. It's the leading cause of cancer-related deaths in women globally, men and women, right? So stressing that, I think, is important. Stressing that there's hope in this field is really exciting, and all the advancements that are coming. We talked a lot about targeted therapies, clinical trials, a lot of potential advancements for patients and their loved ones. So I'm excited about that. And then really just thinking about how we can use social media to spread the word about all of this, to engage, to educate, to empower. I'm 100% on board, and I've loved being a part of the MedFluencers family and really getting to learn from you guys, you seasoned experts who are so good at doing what you do. As a newbie, this is just an incredible experience. So grateful.
Well, we appreciate you joining us. And I think it resonates true when you mentioned you made a post. You have all of these patients messaging you, thanking you for sharing the information. We know what we do is impactful. We love hearing it from external folks like you and appreciate your support. And the last thing we always like to ask, we know at LungOncDoc is where we can find you. Anywhere else you'd like anyone to follow you? Any other call outs that we can add?
No, that's perfect. I'm on X, Instagram, and TikTok, so you can find me there.
Well, we love it. Thank you, Dr.
Yeah.
Singhi, for joining us, and have a great rest of your day.
You're amazing.
Thanks, guys.
Thank you.
Good to see you.